Good morning, everyone. On behalf of Cook Children's, welcome to our 2024 Child Health Summit, Session 2. I'm Lauren Purvis, Director of Child Health Evaluation here at Cook Children's Center for Community Health. If you joined us for Session 1, welcome back. We are so glad that you're here and excited to share more with you today. And we appreciate you, our community partners, for collaborating with us in our efforts to improve the health of children and families in our communities. We hosted the first Regional Child Health Summit in January 2010, so 15 years ago, and shared our initial findings about key children's health issues. As Cook Children's has continued to assess the needs of our community every 3 years since 2009, it's important that we continue sharing the results of our subsequent needs assessments with our community partners. So we thank you for sharing your time with us today. Please be aware that this session will be recorded and made available through our website or social media channels to inform and educate the public on these topics. If you choose to participate in a recognizable way, you acknowledge that your name may be recorded and are authorizing the use of your information in the recording. But you have no obligation to speak or place your information in the chat during our session today, or you can also participate under an alias should you wish to remain anonymous. We do have a full agenda for our Session 2 today. Our agenda includes highlighting our Cook Children's commitment, a refresher of our 2024 CHNA methodology and recap of Session 1 findings, an overview of selected results related to mental health, caregiver support, injury prevention, and oral health, and then a live tour of our data dashboard for further exploration of the data. We've also created some FAQ documents just based on some of the types of questions that we've received in the past. These FAQ documents were included in the pre-event packet, so we encourage you to review those documents when you have time. You're also welcome to place some questions in the Q&A feature, or you can also submit questions to us at any time, either following this event or during the event at chnafeedback@cookchildrens.org. We'll answer any questions received today in a comprehensive document via email that will be sent to all attendees a few days after today's summit. And then we also invite you to complete a post-event survey and provide feedback at the close of today's event. We want to be respectful of your time and ensure that the information we're providing during these summits is helpful for your work. We have several speakers today who are excited to share more about the CHNA, and you can find their full bios in the pre-event packet. We would like to pause and thank our numerous supportive community and research partners. So first and foremost, thank you to Linda Fulmer, our CHNA administrator. We'd also like to thank our many internal departments within Cook Children's who are instrumental throughout our CHNA journey. We brought together an external advisory committee made up of community partners representing our 8 counties within the primary service area who graciously shared their time and insight with us as we were finalizing our parent and community leader surveys. This committee helped create awareness of our surveys during data collection. Some of them provided community leader interviews, and many of these individuals shared incredibly helpful feedback on CHNA materials. So thank you to our external advisory committee members. For well over a century, Cook Children's has been privileged to meet the needs of children and families and communities we serve. And our service area extends to 8 counties, including Collin, Denton, Grayson, Hood, Johnson, Parker, Tarrant, and Wise. Cook Children's relies on CHNA findings to guide community outreach strategies throughout our service area that help fulfill our promise to improve the well-being of every child in our care and communities. We appreciate the importance placed on this assessment by our system leadership. And we also recognize that Cook Children's is just one of many partners committed to improving the health of our communities. Today's health and non-medical drivers of health for families are just too complex for any one entity to address alone. So we know that it takes all of us working together. I'll now turn it over to Mandy Wooliver to review our CHNA methodology and recap Session 1.
Thank you, Lauren. I'm Mandy Wooliver, Research and CHNA Manager here at the Center. If you were with us for Session 1, please hang tight with me for just a few minutes as I give a recap of our 2024 CHNA methodologies and then highlight some of the data that we shared during Session 1, just in case you weren't able to join us. And as Lauren mentioned, we will notify our registrants when the summit recordings do become available. So we aim to apply academic research standards for all of our methodologies. We're going to touch a little bit on each of these methods during our session here today, but the main focus of our data will come from our parent and caregiver survey. I will go into more detail about our parent caregiver survey as well as our community leader survey in the next two following slides, but here I'd like to highlight a few of our other methods. So first, face-to-face interviews with under-resourced families. We work and collaborate with MHMR of Tarrant County to survey an intentional sample of 227 caregivers with families that are experiencing homelessness or with at least one undocumented member. So this sample, we understand, is not the respondents are not representative of our entire service area, but it really does provide a better understanding of the unique challenges that all of these families face with things like accessing healthcare and community resources that are available for their children. Next is moving to family and caregiver interviews. So our community health workers here at the center, they conducted these 27 interviews with families who they built trust with over time. This provides an opportunity for those caregivers to share additional information beyond the questions that are on our parent caregiver survey. Next are patient family interviews. So Dr. Mark Mazade supported these interviews with caregivers of children that were seeking healthcare within our 8-county service area and who speak a language other than English or Spanish. These interviews really offered that opportunity for caregivers to share their experience navigating the North Texas healthcare system, helping identify obstacles to quality care, and provided information on ways to enhance family-centered care, particularly for immigrant families. And in addition, we did conduct community leader interviews. So there were 12 virtual interviews with community leaders across our service area to give us a deeper understanding for what leaders believe are priority needs and concerns for children in their community. And then lastly, we utilize secondary research to further examine all of our priority health issues across each of our counties to determine different national, state, and if available, what the local trends are. So all of these methods together really help us have a better understanding of what the needs are of children in our service area. So moving to our parent caregiver survey, we partner with ETC Institute to conduct our parent caregiver and our community leader survey. So if you were with us for session one, Chris Tatham, who is the CEO of ETC Institute, he was with us to explain these two methodologies. Today, I'm going to provide a quick recap for you. And you can see a lot more detail about these methods and other methods in our full CHNA report. So first, our parent caregiver survey is a statistically valid survey where we gather information from caregivers of children ages 0 to 17 across our service area. The core areas that we assess in the survey are access to healthcare, health insurance, overall health of the child, oral health, emotional and mental health, healthy lifestyles, home safety and neighborhood surroundings, and family and caregiver relationships. So as I'm sure you understand, this is a very robust 57 question survey, but it allows Cook Children's and you, our partners, to better understand the current state of children's health and ways to improve the health and well-being of children. So for sampling, ETC Institute, they utilize address-based stratified sampling, and they select a random sample of households that likely have children under 18 from each of the 14 identified sampling areas. The number of households that's selected is about 7 times the goal for each of these 14 selected areas, which for this 2024 cycle amounted to approximately 43,500 caregivers that were randomly selected to receive the survey. So once that process is complete, the survey is then mailed to those selected households. The survey is offered in English and Spanish, and we do provide that $15 incentive for survey completion because it's just increasingly difficult to receive survey responses. And then the respondents, they could complete the survey via mail, online, or they could actually call as well. So for this cycle, we now utilize a rolling survey. So for 2022, 2023, and 2024, our goal was to sample 2,000 or receive 2,000 responses, getting us to a total of 6,000, and we actually exceeded that number. So it got us to that 6,877 completed surveys. And we also, on the right-hand side, you can see that we have that list of all the counties that we have respondents from, and we look at the child population estimates. So these are census estimates for what the estimated count is for children under the age of 18 in our service area. So for those 8 counties, it's approximately 1.2 million children. And then annually, this data is weighted to ensure the final results reflect the most recent census estimate. So that's in regard to age, race and ethnicity, gender, and household income. And then just as a reminder, it's important to remember throughout our data presentation today that the findings of our parent caregiver survey, they're of the caregiver perception and knowledge. So the findings are descriptive. Now moving to the community leader survey. So we gather information from leaders in Cook Children's 8-county service area to learn about their perspectives on child health issues. The survey was administered via email by the Center for Community Health to our active partners list. And that list ranges from many of you, individuals from city and council governments, public agencies, not-for-profit organizations, independent school districts, faith-based organizations, elected officials, and healthcare. We received 239 responses from leaders for this survey. And again, we understand this survey is not representative of our entire 8-county service area, but we really did intentionally strive to collect a good response rate from each of our counties and different roles within the community. And so on the right-hand side of the slide, the figure shows the breakdown of correspondents and their role in the community. So a majority of the respondents were from social service and nonprofit professionals, healthcare providers, and government and public health professionals. We did have representation from each of our 8 counties. So through our assessment, we want to keep in mind the impact of non-medical drivers on children's health and well-being, so particularly those that are from under-resourced families and communities. So as you can see much further and in more detail in our executive summary and our full CHNA report, we utilize the HELP framework, HELP, which is Health, Environment, Learning, and Parenting. And we integrate insights from what we learn from caregivers and community leaders to really get that overall picture of the needs in our service area. So I promise we're almost on to new information for you, but as the last recap from session 1, we wanted to share a few highlights from each of those sections. So first, for community concerns, we identified 4 factors: inflation, housing affordability, food insecurity, and childcare costs that continue to arise across our data collection methods and through our secondary research. So rising inflation continues to stretch household budgets, making basic needs just difficult to afford for families. Housing affordability remains a major concern, with many families just struggling to secure stable, safe, and affordable homes and rent. We also heard time over time about persistent food insecurity, which is directly impacting families and especially children's health and learning. And finally, childcare costs, they're not only a financial burden, but they're also a barrier to workplace participation and then that access to early education. And moving to overall health and well-being, the good news is that 84% of children, so almost 1 million children, are in excellent or very good health according to their caregiver, and 76% are getting all the healthcare they need. So this really speaks to the effectiveness of many of our healthcare systems and programs. However, there are about 12% of children that do not have continuous insurance coverage, which does impact access to care. And next is asthma. So asthma continues to be that significant issue affecting children. 9% of children currently are living with asthma, which is over 100,000 children. And of those children, 25% had to visit an emergency room for asthma symptoms, and 19% do not have an individualized asthma action plan. And lastly, when we look at healthy lifestyles, 38% of children ages 10 to 17 have an unhealthy body weight, which has long-term health implications. Only 19% of children are getting the recommended daily physical activity, and 34% of children, which is over 390,000 children, live in households that cannot always afford nutritious meals. So as a reminder, I'd like to outline what you'll see on the following slides for mental health, caregiver support, injury prevention, and oral health. Our parent caregiver survey results will be highlighted in any table that is shown. You will also see data from our 2022 or from the 2022 National Survey of Children's Health, or NSCH. We compare our results to the national survey when that's appropriate. You will also see our under-resourced results, and as a reminder, that's from families that are experiencing homelessness or living with an undocumented member. And then for this session today, we do have data from our healthcare analytics team that really highlights what we're seeing in the Cook Children's Medical Centers in Fort Worth and in Prosper. And so with all of that in mind, I'm now going to transition to Courtney Bernard to kick us off and discuss our mental health findings.
Hi, thank you, Mandy. Hi, everyone. Good morning. I am Courtney Bernard. I'm the director of the Child Wellness Team at the Center for Community Health, and one of the areas I oversee is children's mental health. So when we talk about this topic, we know that mental health is a strong determinant of overall quality of life. It involves a child's ability to reach certain developmental and emotional milestones, engage with others in social settings, and cope with the challenges that may arise. In 2021, the major pediatric healthcare organizations all declared a national state of emergency in child and adolescent mental health, which remains a pressing issue today. So in our 8-county service area, approximately 29% of children ages 6 to 17 years old, they have a diagnosed mental health condition. That's about 237,000 kids with a diagnosed mental health condition. The top 2 reported diagnoses are anxiety and ADHD, followed by depression and behavioral problems. On the other side of the statistic, in our service area, we know that 72% of children ages 6 to 17 have excellent or very good mental health status according to their caregiver. We also asked our community leaders during the interviews to rank the most needed health services in their community, and all leaders shared that the need for mental health care or counseling services is their highest priority. Access to mental health care is a critical factor in supporting the healthy development of children, yet we know many families face challenges in getting the care their child needs. In our service area, 36% of children needed mental health treatment or counseling. That's about 270,000 children. And of these kids who needed mental health treatment or counseling, 48% experienced difficulty in accessing the needed care, and 6% said it was not possible to get the needed mental health treatment or counseling. And one community leader shared with us, it's changing, but there's still a lot to do. There are not enough providers. However, the stigma associated with seeking care leads families to underutilize the resources. So we can see that there are multiple factors impacting access to care. Moving forward onto mental health support, about 19% of children have missed more than one day of school due to mental or emotional concerns. So it's impacting their daily functioning. And 35% of children, or 252,000 children, have a caregiver who is asked by their healthcare provider or educator if they had concerns about their child's mental health. And 38% were asked if they had concerns about their child's learning, development, or behavior. So this is a great a great thing here. This is an area where healthcare providers, educators, or other professionals with close interaction with a child can help initiate those timely conversations for evaluation and interventions if needed. Caregivers may notice certain behaviors in their child, and when given the opportunity from others to express these concerns, it can help validate the caregiver's role in their child's development and create a bridge to essential services, making a meaningful difference in a child's long-term mental health outcomes. In addition, 70% of caregivers from our parent caregiver survey, and less so from our under-resourced families at 57%, said they are very or somewhat familiar with the mental health services in their community. So now I'm going to share with you a quote about social media challenges that will lead us into the topic for the next slide. And that is the bullying, stigma, and body dysmorphia. Social media can be so negative, and we need to figure out how to use it in a positive way. Kids form their beliefs, and social media has an outsized role. But kids don't know how to judge the factual content from the exaggerated stuff. It leads to more mental health issues. Those are what you can't necessarily see, and it starts with the mind. So as we talk about this topic of social media and internet use, when asked in our parent caregiver survey, approximately half of the children have a caregiver who is always in communication with them about internet safety. This is awesome. But this also means the other half of families are not having those same conversations as often. And so while lengthy, I would like to also read you this quote on the screen here from Dr. Lisa Elliott. She is a neuropsychologist and manager of Cook Children's Behavioral Health Clinic in Denton. And you can see her full quote in the mental health section of our CHNA report. But she speaks to the impact of screen time and social media. So her quote, "We now have significant evidence-based research that has shown the harmful impact of too much screen time, whether that is in video games, mindless games on a screen, YouTube, social media, etc. The negative impact is profound, permanently damaging the structure and functionality of our brains. Not to mention, we have proof of technology addiction. It is critical that parents have discussions with their kids weekly about phone use, to check their devices, to stay educated about technology, put safeguards and contracts for device use in place, and even more importantly, to model healthy screen use with their kids." End quote. So I'd like to wrap this section up by sharing with you the perspective of mental health directly from children in our community. At Cook Children's, we have an activity called Children's Feelings Are a Work of Art that educates, raises awareness, and reduces the stigma surrounding children's mental health. Children learn about feelings, how to identify them, and then are encouraged to express themselves in a healthy way through art with others. This artwork is then displayed in the community to celebrate the participating children and encourage healthy conversations about mental health. So here's a few examples. On the screen on the far left, we have Adeline, who's in 4th grade. In her image shows how feelings can mix up and how to talk about it. Or in the middle, Everly, also in 4th grade. "My feelings are like leaves on a tree. They fall and grow back, and some are bigger than others." And Wyatt on the far right, 2nd grade. "This piece represents sadness and how I tend to put my own sadness in the back of my mind. Eventually, it will find a way out, and that is okay." And then a final 2 pieces. While this initiative isn't focused on the technical art skills of children, sometimes they do create stunning pieces through this activity, like Kaylee, age 14, in her image of the tiger, "Let me be free." I think this piece represents being overwhelmed. The background is sort of the ever-shifting pressure all around the subject, the chains representing being held back by stress. Or Prutov on the right, in his image, age 12, hope within. You fall, you fail, but every sunrise gives you a hope to try all over again. So I love that we can share not only the data points that come from our parents and caregivers and our community members that help us understand the landscape of children's mental health in our community, but that we can also hear directly from the children about their experiences, whether or not they have a diagnosis, a mental health diagnosis, or need treatment. And again, we can combine all of this information together to help us identify where and how we can continue to improve the overall well-being of children. So now I will hand it over to my colleague Brianna Anderson to share about caregiver support.
Those are such impactful pieces, Courtney. Beautiful. Hello, everyone. I'm Brianna Anderson, and I'm so honored to be here today to discuss caregiver support data from our recent CHNA. I manage our Build a Bridge team at the Center for Community Health, which is focused on building protective factors at a family level. So this topic is near and dear to my heart. In August 2024, the U.S. Surgeon General called to attention an urgent public health issue, parental mental health and well-being. The advisory emphasizes the significant stress parents face from financial instability, work-life balance, children's health, technology, social media, and the lack of social support. In our 8-county service area, 18%, which represents over 216,000 children, have at least 2 ACEs. Adverse childhood experiences, or ACEs, are traumatic events that occur during childhood that can have lasting mental and physical health effects well into adulthood. We assessed 10 ACEs on our parent and caregiver survey to align with the National Survey of Children's Health. And you can see the percentage of children experiencing 2 or more ACEs aligns with Texas and the US. The list of adverse experiences is robust and includes multiple aspects such as experiencing child abuse and neglect, witnessing violence, as well as home and neighborhood safety. ACEs are common, but certain factors increase the risk. These factors include poor parent-child relationships, high parenting stress and economic stress, living in communities with high rates of poverty, and limited education and economic opportunities. For the sake of time, I will not be listing all 10 of the ACEs examined, but they are listed in the caregiver support section of the CHNA report. I will highlight the top 5 reported ACEs from our parent caregiver survey. In our 8-county service area, the highest reported ACEs was hard to cover basics on family income, which is approximately 185,000 children. This was a new item added to the NSCH, our most recent CHNA survey, and quickly rose to the most predominant ACE, closely followed by parent or guardian separation. Continuing down the list for our 8-county service area was the question about children living with someone who is mentally ill, suicidal, or severely depressed, living with someone who had a problem with drugs or alcohol, and saw or heard parents or adults slap, hit, kick, or punch one another in the home. Looking at our under-resourced results, the top 2 were the same as what we saw in the parent caregiver survey. Then we saw domestic violence rise, followed by parent or guardian serving jail time, and then living with someone who had a problem with alcohol or drugs. For the 216,600 children in the 8-county service area that have at least 2 ACEs compared to children who have no ACEs, they are 2 times more likely to report fair or poor overall oral health, 2 times more likely to report not receiving all needed medical care, 3 times more likely to report fair or poor mental health, and 3 times more likely to report not always being able to afford to eat nutritious meals. Also, children with 2 or more ACEs are less likely to meet daily healthy lifestyle recommendations, including physical activity, eating fruits and vegetables, having a family meal with household members, sleeping at least 8 hours per night, and limiting fun screen time. Specific to school-age children, approximately 19% of school-age children, which represents about 157,000 children, have 2 or more ACEs. Compared to children with no ACEs, these children are less likely to care about doing well in school, more likely to bully others and get bullied themselves, and more likely to have been diagnosed with at least one of the 4 most common mental health conditions, which includes ADHD and ADD, anxiety, behavioral and conduct problems, and depression. Dr. Elizabeth Peeler, a pediatrician and member of Cook Children's Child Advocacy Resource and Evaluation, or our CARE team, shared, exposure to adverse childhood experiences and other traumatic events can affect the health and wellness of children. That is why it is important for health professionals to be knowledgeable and mindful of trauma-informed care. We can help create safe environments and bolster resiliency. We can make a difference. Supporting caregivers during pregnancy, the 4th trimester, or the first 12 weeks after birth and beyond lays the foundation for healthier childhood outcomes. Studies indicate that when caregivers receive consistent emotional, physical, and social support, they are better equipped to nurture secure attachments, support development, and positively influence long-term health outcomes in their children. In our service area, approximately 57% of children, or about 668,000 children, have caregivers in the 8-county service area reporting that they are coping very well with day-to-day demands of raising children, which aligns with Texas and national estimates. Additionally, a majority of children have caregivers, 81%, who report having a social or emotional support, a source of emotional support with parenting or raising children, which positively exceeds Texas at 72% and national at 76% estimates. Since the 2021 CHNA, 2 trends worth emphasizing are 1, a slight increase in caregivers reporting that they are coping very well with parenting demands, and 2, a continued decrease in caregivers reporting they have a source of emotional support with parenting. The top 3 reported sources of support include a spouse or domestic partner, other family or close friends, and, interesting, a healthcare provider. One caregiver shared with us, if I had accessibility to childcare or even just assistance in how to parent, Caregiver Alliance, which is a shout out to our programming, gives me tips or tricks from other parents. Alternatively, even just someone there when I leave the doctor's office. If I had someone there that made sure I understand everything, such as medications and side effects, and certain medications that affect how you eat or sleep, even the pharmacists, they just ask if you have any questions, and that's it. We would not be having this conversation, though, if there are not ways to combat these challenges in order for every child to thrive. Resiliency, which is recognized as the counterpart to ACEs, can be built through protective factors such as strong relationships, social support, and safe and nurturing environments. However, this will take a concerted effort on all of our parts. We all have a role in this work. If this is an area of interest, the CDC has a number of strategies at an individual, community, or organizational level available online. This link was just provided in the chat. Now I will hand it off to Dana Walraven to cover injury prevention data.
Hi, my name is Dana Walraven, Strategic Partnerships Manager within the Center for Community Health, and I'll be sharing key findings with you on injury prevention. Unintentional injuries, also known as accidental injuries, include both non-fatal and fatal injuries that occur without deliberate intent to cause harm. According to the CDC, unintentional injuries are the leading cause of death for youth ages 1 to 17. And in our 8-county service area, 20% of children received emergency care for an unintentional injury. That's about 233,000 children. Age-specific patterns for unintentional injury include infants less than 1 year of age. Suffocation-related injuries are most common. And for children ages 1 to 4, drowning is the leading cause of unintentional death. And for 5 to 17-year-olds, it's motor vehicle crashes. Approximately 22% of school-aged children missed more than one day of school due to an unintentional injury. Now, missing school does not only disrupt their education, but also places additional strain on caregivers who may struggle with missed work. As I mentioned, drowning prevention is so important, with drownings as the leading cause of unintentional injury, with children at highest risk between the ages of 1 to 4. According to the survey, approximately 80% of 1 to 4-year-olds were always in reach of an adult during swim time and bath time. For children ages 5 to 11, notice the decrease here in children that are always supervised around water or pools at 72%, and only 36% of children always wearing a life jacket around water or pools. That's important when we consider other areas of water too, such as lakes or ponds, and even along the coast. For children ages 12 to 17, only 47% always wear a life jacket around water or pools. And as far as patient care, from 2021 to 2023, Cook Children's Medical Centers in Fort Worth and Prosper have treated 224 drowning-related injuries. A community leader shared, "What most parents don't know is that teaching kids how to swim is just the beginning." And that's so true. When it comes to preventing injuries, layers of protection are always best practice. Swim lessons are key, but preventing access to water during unplanned swim time, as well as establishing pool rules and ensuring adult in-reach supervision without distraction during planned swim time, is also very important in preventing drownings. Now, preventing firearm injuries is also of great importance. In fact, in 2024, the U.S. Surgeon General issued an advisory on the public health crisis, firearm violence in the United States. In 2022, firearm injuries were the leading cause of death among children and teens ages 1 to 19. Best practice is to always keep firearms and ammunition locked up safely, whether it's stored inside a home or in a vehicle, in order to prevent child access. Of households with guns in the 8-county service area, approximately 79% of children live in a home where firearms are always locked away, and 76% where ammunition is always stored separately from guns. To put that in perspective, that speaks to about 454,000 children from this survey alone. While the percentages reported look high, it's important to consider the thousands that are not locked up safely and may more easily result in injury to a child. Across Cook Children's Medical Centers from 2021 to 2023, 23 patients were treated for injuries related to firearms and handguns, and 44 patients for injuries related to other gun types, such as BB guns or airsoft guns. That's right, all types of guns can cause severe injuries or death. Dr. Dan Guzman, pediatric emergency medicine physician and founder of the Aim for Safety program, shared, "Unfortunately, we see this tragedy of unintended fatal shootings many times a year in our emergency department at Cook Children's, which has a long-lasting effect on families as well as staff." And as far as motor vehicles, the risk of severe injuries and fatalities in crashes can greatly be reduced by ensuring that children are correctly secured in car seats, in booster seats, or seatbelts that are appropriate for their age and size. Research shows that compared to using seatbelts alone, car seats can reduce the risk of injury in a crash by 71 to 81% for children. In our service area for children ages 1 to 4, 78% always ride in a car seat, while 48% of children ages 5 to 11 always ride in a car seat or booster seat. And from 2021 to 2023, Cook Children's Medical Centers treated 2,000 366 non-fatal injuries related to motor vehicle crashes and 611 related to ATV or off-road vehicle injuries. And children of all ages are at risk of poisoning for different reasons. For instance, infants, they are often incorrectly dosed with medications, and toddlers are interested in exploring everything and often mistake poisons like medicine or household cleaners for candy or juice. Then we have school-age children who may take medication without supervision, and teens who are exposed to social media and peer pressure, leading to the use of substances that are not prescribed to them. In our 8-county service area, only 44% of children live in a home where cleaning products are always locked away, and 48% of children live in a home where medications are always locked away. Again, think about that percentage, and that the remaining are not always locked away. That's quite a bit. Specific to substance use, approximately half of children between the ages of 12 to 17 are always taking their caregiver, or talking to their caregiver about drugs or alcohol. An important quote from Dr. R.T. Gandhi, a Cook children's physician who's board certified in pain management, shared, "Medications come in all different shapes and sizes, often look like candy, and are made to taste good. They can even be liquid or gummies, over the counter, prescribed, or even fake. It is vitally important to talk to kids about medication safety, which includes use, storage, and disposal. They should only take medicines prescribed by a physician, given by a nurse, or a trusted adult. Counterfeit medications may be laced with dangerous substances that can be life-threatening and not worth the risk." So our injury data concludes with sudden unexpected infant death, or SUID, which is a tragic event often resulting from unsafe sleep environments. SUID includes sudden infant death syndrome, or SIDS, accidental suffocation and strangulation in bed, or ASSB, and other sleep-related deaths. Ensuring a safe sleep environment is critical, which means placing babies on their backs to sleep, using a firm mattress with a fitted sheet, and keeping the crib free of objects that could pose a suffocation risk. In our 8-county service area, approximately 75% of infants are always placed on their back to sleep, but only 58% of children always sleep alone in their bed or crib. Sharing a room is fine, but not the bed. The Texas Department of Family and Protective Services shared that in Texas between 2021 and 2023, 506 infant deaths occurred where bed sharing was a factor. Lastly, Save Baby Sleep Council member and a labor and delivery nurse, Keely Douglas, explained, "There are many ways that caregivers attempt to bring comfort to a sleeping infant, but do not realize the dangers it may cause. Why it's important is to follow the ABCs of Z's, alone, on their back, and in a crib. We believe that it is our job as community professionals to give parents the best information and safety practices that are available regarding safe sleep. Far too many babies are lost due to accidental suffocation, and it is the leading cause of injury-related deaths in little ones less than 1 year old." I'll now turn it over to Dr. Tanya Fuqua with Oral Health.
Hello, thank you, Dana. My name is Dr. Tanya Fuqua, and I am very honored to be the Dental Integration Director for Cook Children's Center for Community Health. So good oral health is a critical part of overall health for a child, for all of us. In the U.S., cavities, also known as caries or tooth decay, or I like to say sugar bugs for children, is the most common chronic childhood disease, but the most preventable. In our 8-county service area, Approximately 29% of children, this equivalates to about 328,000 children, have good, fair, or poor oral health. Poor oral health can negatively impact a child's physical, emotional, social development. It can impact their speech. It can impact their ability to be able to eat and get the proper nutrition they need. Children with poor oral health often have lower self-esteem. They can be missing school because of dental pain or not even knowing that that's part of their problem. Children perform less academically as well. Oral health affects more than just the mouth. It is connected to the rest of the body, and it can impact a child's ability to sleep, concentrate, or succeed in school. I don't know if any of you out there have had a toothache, but if not, just think about having the worst headache ever, 10 times worse. The American Academy of Pediatric Dentistry recommends that children receive preventive dental care every 6 months. Yes, that's twice a year. Ideally, we would want children to be seen by their first birthday to prevent any oral health problems. In our service area alone, 57% of children received at least 2 or more preventive dental visits, which does align with the AAPD's recommendations. However, approximately 12% of these children, 140,000 kids, did not receive all the dental care that they needed this past year. Specific to dental insurance coverage, 46% of children have private dental insurance or coverage. 25% had Medicaid or CHIP for routine dental cares, cleaning, dental checkups, exams. Almost 25% of community leaders surveyed indicated it is difficult for children to access preventive dental care and treatment for their dental problems. You'll see a quote here from one of our community leaders stating that there are not enough providers, and of those that are available, not many families can afford to utilize them. So even more so, there is a lack of knowledge and awareness of the importance of oral health on the growth and development of a child. So yes, even our own healthcare providers, we all need to support each other in this. Approximately 19% of children, this is 218,000 kids, experience chronic or frequent dental problems. This is 20% of school-age children. 150,000 kids have missed school due to dental pain. That should not be why kids are missing school. Since children visit pediatricians more frequently than they do the dentist, this is definitely an opportunity for collaboration between our medical and dental professionals. Medical and dental integration is evidence-based. It is the way that we can improve overall health outcomes for our kids and obviously set up great best practices for a lifetime. In our service area, 69% of children had a medical professional who recommended a dental visit. Great job, dental professionals. This is great to see, but this is not necessarily the norm, unfortunately. And 35% were advised, though, to visit a dentist because they were having a dental problem. Medical and dental integration has been shown to reduce health disparities, especially among our under-resourced populations. To share a quote here, you can see on the screen from a caregiver, I really liked the oral health program. This is one of the programs under the Center for Community Health. It helps me and encourages me into making the physical and dental appointments for both my kids. I also appreciated the community health worker taking her time to come to my home and check in and make sure that these families are getting and following up with the care that they need. Families are facing a lot of things, as we have seen throughout this presentation today. Dental care is no exception to that. Lastly, I want to share that in the 8-county service area, about 62% of children, that is 726,000 kids, caregivers, who are unaware that a child must see or should see a dentist by their first birthday, by age 1. Early oral health visits allow for the detection of early disease, allows us to provide treatment in a non-invasive way, and to provide our caregivers with guidance and maintaining or improving their child's health. And of course, can reduce the invasive and potentially costly dental care of maybe even an emergency room visit. Unfortunately, here at Cook Children's, we can say that this is not a great statistic, but one of the top or second highest outpatient procedures is for dental. So, however, in the 8-county service area, we do have about 10% of children that do have a caregiver that is somewhat unfamiliar or familiar with dental services in our community. They're not sure where to go or where to get help that they need. Also, an often overlooked opportunity is early education and awareness with our pregnant prenatal population. During pregnancy, oral health conditions like dental cavities, caries, gingivitis, periodontal disease, these are very common, unfortunately, during pregnancy, and these things can lead to low birth weight babies or even early preterm labor or worse. Increased awareness can contribute to better health outcomes for both mother and baby. And the earlier we start and prevention we instill, the better off we're all going to be. We must connect the dots. It is important for oral health to be included in overall health. The mouth, after all, is the gateway to the body. Thank you for letting me share oral health information today, and I'm going to turn it over to Miss Savannah.
Hi, everyone. My name is Savannah Panagopoulos, and I'm one of the community health analysts on the Child Health Evaluation team here at the Center for Community Health. So next, I'm going to discuss our calls to action based on the data that we've learned today, give you a walk of our data dashboard, and also discuss some next steps. Now, let's discuss our calls to action based on the data that we have learned today. These calls to action are framed from the perspective of collaboration, outreach, and advocacy. For collaboration efforts to address mental health, it is vital to support mental health providers with care, coordination, and professional development opportunities. In order to reach and inform communities on children's health, we must provide caregiver and community trainings on the signs of mental health disorders in children, building healthy coping skills, and access to care and resources. We must also focus on expanding the reach of mental health messaging to connect families with care and reduce stigma. Collaboration efforts for caregiver support include providing resources and trainings specific to positive childhood experiences to combat adverse childhood experiences and build family and community resiliency to create nurturing environments. Caregiver support begins at the earliest stages of life. Which is why outreach efforts must connect families to maternal and infant health services, including postpartum mental health support and local resources addressing the non-medical drivers of health. Advocacy for caregiver support includes supporting community campaigns and events to increase access to critical resources for children and families. Injury prevention collaboration efforts include the development and strengthening of partnerships to increase the reach of injury prevention messaging, resources, and education. To increase the awareness of the importance of injury prevention for children and caregivers, outreach efforts involve providing evidence-based resources, prevention tools such as medication lockboxes, sleep sacks, and life jackets, and education and training opportunities. Additionally, advocacy for public policy changes that support injury prevention, such as child restraint laws, distracted driving messaging, and pool ordinances, are necessary to increase preventable injuries. To better achieve positive oral health outcomes, collaboration through medical-dental integration is necessary to enhance coordinated care services. Outreach efforts involve improving access to preventative dental care and prompt treatment, especially for children who have higher rates of oral health disease. Lastly, advocacy for oral health involves raising awareness in the community about proper oral health practice and the importance of equal access to oral health care. Now, the CHNA report includes more in-depth training and collaboration opportunities at the end of each health topic section. And we do have a full list of implementation strategies, which can also be found on the website with the full 2024 report. These implementation strategy plans describe specific strategies, key resources, and program champions, which guide the priority health programs to address the needs identified in this assessment. Separate strategy plans are in place for the Cook Children's Medical Center in Fort Worth, as well as in Prosper. Now we'd like to show you a short, comprehensive video that will align how we use the data we have discovered in this needs assessment to address our next step. The CHNA report provides a roadmap for the work that we will lead and support in our communities over the next 3 years. This means the strategies we create to implement through our programs and our partner collaborations are data-driven and address the needs identified by our community.
How do you improve the health and well-being of over 1 million children across 8 counties? Well, it takes a lot of planning, a lot of collaboration, and it takes a lot of support from people like you. Every 3 years, the Center for Community Health pulls together important data from the public through the Cook Children's Community Health Needs Assessment. That information helps us to build strategies to meet our region's most pressing needs through our programs and through our collaborations and community partners. We then work diligently to track our success. Are we all moving the needle like we want? Are we making a difference? This work is bold and big. Change at the community level often takes decades to fully integrate, but progress is being made daily through all our dedicated partners working together. We report on our progress annually to the government, state and federal, as well as to Cook Children's leadership and other internal departments. We also celebrate this progress with our collaborative partners and build on the collective wisdom our shared experience provides. Our community health needs assessments, ever since our first one in 2009, validate the work we do through our collaborations and programs. The data also guides us on how and where we do our outreach. It's data-driven decision-making so that everyone benefits. As we review the most recent assessment data to create strategies for the next 3 years, we take into consideration what has changed in the communities. Are there changes in available resources? Are there new methods to address the needs? We also rely on our partners who live and work in each community to provide helpful context on key people and organizations to work with, approaches that have been successful, and where there are gaps we might help bridge. A few examples of how we utilize our assessment data include: determine new ways to support equitable access to care for all children, determine locations for loaner life jacket stations, expand parent support and mental health educational topics, develop a program to identify and remove asthma triggers in the home, strengthen oral health messaging for families and pregnant women, provide education opportunities promoting safe sleep practices, increase community education efforts around nutrition and food insecurity. We then recommend revised strategies to Cook Children's leadership. Once approved, we have a roadmap for the work we will lead or support in our communities over the next 3 years. Every year, we coordinate progress reports that outline the incredible work our programs and collaborations are doing to improve the health of children in our region. Gathering this information from families, leaders, and partners is a fundamental element in our efforts to help each child reach their full potential. The overall process is definitely an investment, one that will serve our community well for decades to come. Thank you for the part you play in improving the lives of children and families. Visit our website to learn more.
Now let's take a look at the community leader and parent caregiver data dashboards. So we're going to do a short tour so that you can see what data and features are available for you to access. So first, you'll have to hit I agree to the data restriction disclosure in order to view the board. You can also expand the board by using the arrow down here on the right corner to make it larger and easier to view. The 2024 CHNA uses the data that was collected during the 2023 year for our leader survey. The 2021 leader survey is also available to view on this dashboard. And leader data is collected once during a CHNA cycle. So if you don't select a specific year to view, the dashboard will show you both 2021 and 2023 results together. I'm going to go ahead and select our 2023 year. So our leader survey of 10 questions is broken down into the 4 tabs here at the top. These results are an accumulation of leader responses from all counties that are combined. So because this is a much smaller survey compared to the parent caregiver one, these results are not broken down by specific county. So based on the question, you can select from the tab the answer response, and the response percentages will be listed as you click through the answers. You can also hover over the bars on the bar chart, and it will also tell you what the answer response was as well as the percentages. Now, if you would like to view the entire survey and answer responses, you can click the link down there at the bottom of the screen, and it will take you to the actual leader survey. Now let's go ahead and take a look at our parent and caregiver dashboard. So you may have to hit the I agree to the data use restrictions again. Now the first tab that you'll land on is known as our key indicators tab. And these indicators correspond with the priority health issues that have been identified for children most commonly throughout our communities. So you can see that the key indicators for 2021 and 2024 are both listed. But it's important to note that while we do refer to past CHNAs to look at overall trends, we do not exactly compare previous CHNA results to current ones due to different families or leaders that are surveyed, as well as changes due to expansion in our different service area. Next, the 57 question survey is divided into sections in the different colored tabs located here at the top of the dashboard. Now, there are several different ways in which the data will be displayed for you to view. So our default view will show you what's known as county on the results by tab. And then you'll see at the top the overall results, which is the 8 county service area data compiled, which is what you've heard throughout the summit. It will also show you the individual county breakdowns as well. Now, when you hover over these data points, you will see the answer choice along with the weight and the estimated number of children. Now, again, this weighted estimate signifies about how many children the survey responses represent from the entire child population based on the recent census estimates. Then, where this question applies, you can also look at a breakdown by child's age group. So you may have to collapse or open up these little arrows on the side of the results as well as questions. So if we select age breakdown, you can see this answer response for children 1 to 4 years of age, 5 to 11, or 12 to 17. Next, you can also see the data results by annual household income, which we have broken down into 4 different categories, as well as the child's race and ethnicity reported on the survey, and our special population survey, which you also know as the under-resourced sample, which again is an unweighted sample. Now let's take a look at an example of how you might utilize the data on the dashboard. So I'm going to stay here on the oral health tab since we just heard about data related to this topic. Say that you are in an organization working on connecting the dots between medical and dental integration, but you'd like to gauge how many caregivers are receiving those recommendations to have preventive dental appointments from their medical professionals, likely when they're attending a medical appointment. So I'm going to collapse this arrow down here and expand to see that answer or that question response. So you can see that for the overall 8-county area, 69% or about 776,000 children received a recommendation for preventive oral care from a medical professional. Maybe you'd also like to know what age groups are least likely or more likely to receive a recommendation. So I'll go here and select the age breakdown on the results tab, and I can see the difference between the 1 to 4 years old group, the 5 to 11, and the 12 to 17. Now, this data could inform your organization on ways to collaborate with medical staff on the importance of spreading awareness and knowledge about timely preventive oral health care, starting as early as 1 year of age while they're already attending a medical appointment. Now you can also view the 57-question survey by clicking the link down at the bottom of the dashboard, which will provide you with all of the questions and survey answers. If you have questions or comments about the data that you're viewing, our email is also listed here on the top of the data dashboard. And just as a reminder, our data dashboard is updated after a full CHNA cycle is complete. So that's why you can see the 2021 and then now our 2024. And our next one that will be available will be 2027 when ready. Now I'll return to the presentation for a few minutes to gather your feedback and provide some additional resources. Now the full 2024 CHNA report can be found on our website along with our implementation strategies by scanning the QR code there on the screen. Please visit our website at cookchildrenscommunity.org to further explore our Center for Community Health programs mentioned here today and from Summit 1, as well as explore education and training opportunities that are available to caregivers and professionals in the community. That concludes the Session 2 Summit for today. Thank you for joining us. We look forward to your feedback and we hope that you have a great day.